Welcome to the Mad in America podcast, your source for science, psychiatry, and social justice. Hello, this is James, and welcome to the podcast. And this week we hear from Dr. Adam Urato. Adam graduated from Harvard Medical School in 1997 and has been practicing medicine for over 25 years, specializing in obstetrics and gynecology. He cares for pregnant women on a daily basis as an attending maternal-fetal medicine physician at MetroWest Medical Center in Framingham, Massachusetts. He also writes and lectures regularly on antidepressant use during pregnancy. Adam has contributed to Mad in America's continuing education efforts, and his free course, Antidepressants and Pregnancy, can be found on Mad in America's education section. And I highly recommend that you watch it, as it's an informative and comprehensive look into a little discussed but very important area of women's health. For this interview, Adam joined me to discuss what we do and don't know about the effects of antidepressants on babies and mothers, and also the importance of counselling in order to aid families in making important decisions about pharmaceutical drug use. Dr. Urato, Adam, welcome. Thank you so much for joining me today for the Mad in America podcast. I have to say that you're someone that I'm really excited that we can get to talk to, and we've had a lot of interest in hearing from someone with your kind of particular skills and abilities. So thank you for joining us.
It's a real pleasure to be here, and thanks for having me.
Great, thank you. You're a specialist in obstetrics and gynecology, and you've been practicing medicine for over 20 years now. But in addition, I think it's fair to say you developed a critical view of the way that some prescription drugs are used for pregnant women. So to kind of get us underway, I wondered if you could tell us a little bit about you and how you came to have the interests that you have, and what was it perhaps that led you to question some of the conventional wisdom in this area?
Sure. I think it's a great question. I went into obstetrics because when I came through med school, it was a really cool thing. I really loved. I love doing it. It's a great, and I'm very grateful that I'm able to do this every day. It's a very diverse field as far as what we're doing on a day-to-day basis. And we're taking care of pregnancy and pregnant women, but we end up dealing with the medical issues, surgical issues. Certainly, I still deliver babies, so do operations, C-sections, and vaginal deliveries, and deal with that aspect of it, as well as the in-office things. Most of the time I'm doing ultrasound. I'm a full-time clinician. I take care of patients all day, all the time. And in my hometown, I take care of patients at the hospital where I was born, which is a real pleasure for me. It's really great to be active in my hometown, my home community where I grew up, where I was born and raised. And I think the other element to it, honestly, is that it's a miracle. It really is, the developing baby and life. And I know that sounds a little bit corny, but it really is. It's a great job to have. And as I said, I'm very grateful I have a chance to do it. As far as my interest goes in medications, I think this is something that I began to get interested in medical school. When I was seeing how many medications our patients were on. I remember when I did my internal medicine rotation, my chief resident told me that we used to write with paper and pen at the time. They said, when they come in, fold up your paper, and on the right side of the paper, you make a list of all their medications, and it'll typically be anywhere between 10 and 15 to 20 medications. And I remember thinking at the time, like, what are the interactions between all of these medications that we're using? And then when I did my obstetrics and eventually I did residency in obstetrics and gynecology, I remember hearing the discussions about, well, this drug is safe in pregnancy. And it really got me to thinking about drugs and drug safety. One of my overarching sort of approaches to this that I really try to emphasize to people is that medications, for the most part, are synthetic chemical compounds. And I really try to get people to think about that and understand it, because I think that the pharmaceutical industry has done a great job at sort of portraying them in their ads and the commercials that we have over here, and even in their print ads, as blue skies and trees and beaches and rainbows and all of these sorts of things that kind of distract you and take your eye off the ball a little bit. At the end of the day, medications are synthetic chemical compounds. They're coming out of a chemical factory, and they have chemical effects. That's what chemicals do. They have chemical effects. And so I think I was looking, even as a medical student, when I was looking at the lists of medications, 15 or 20 medications, and seeing that as a large number of chemicals that these patients were ingesting. And then certainly as pertains to pregnancy, with the issues about chemical exposure to a developing fetus.
Yeah, absolutely. Thank you for sharing that. I mentioned in our intro that the continuing education course you did for Mad in America, which, I recommend that people go and watch. And I think the phrase you used in that was chemicals have consequences. And that really stuck with me. It's such a useful phrase to have in mind when, as you say, we're sold some medications almost as if they're a kind of a lifestyle accessory almost, but really, they really are, as you say, chemical compounds that have effects on the body.
You just made my day by using that phrase, because it's one that I use commonly. And I think my sons would say, "Oh my God, there's Dad using that phrase again." But yeah, that's something that I think is important to get across to people, is that chemicals have consequences. Chemical compounds have chemical effects in biologic systems. That's what they do. And for us to always keep that in mind. It doesn't mean you can't use a medication. It doesn't mean you can't take a medication. But it means that whenever you're taking it, you need to keep in mind that it is a chemical and that it does have chemical effects, and then be able to balance out, well, is the benefit I'm going to get from this going to offset these chemical effects? I actually encourage people to really embrace this. And if you're going to take a medication or thinking about taking a medication, it's worth even looking it up, the chemical structure, on Google or some other site, just to see. You'll see the rings, the carbon atoms, the nitrogens or whatnot, and understand that this is a synthetic chemical compound that you're about to ingest, and that it's going to go into not just the location of what you're trying to address, like if you have a headache, to your head, or if your knee hurts, to your knee. It's typically going all over your body, throughout all of your cells, and going to have consequences, going to have a chemical impact.
Yeah, absolutely. Thank you, Adams. Thank you so much. So, to talk perhaps about some of those effects a little bit more. So, people listening will know that serotonin is often talked about as being important in the treatment of depression, which I think it's fair to say in itself is a bit questionable. But it turns out that serotonin is pretty crucial in fetal development. So, I wondered if you could share with us a little bit about this, and then why we should be concerned about the effects of SSRIs on the mother's body as well.
Sure, absolutely. Before I go on, I do just want to jump in, and I do just want to make one point clear, which is that I think you're asking me excellent questions, and I think a lot of times, though, people hear these questions and they hear the answers to them, and what they're hearing is, then this means that a pregnant woman should not be maintained on the medication. And I just wanted to make it clear that that's actually a separate question, and that's something that I hope we can get into later. But pregnant women who are suffering from depression during pregnancy or other mental health issues, they need compassion, they need good care, and they shouldn't be ignored or left to suffer. And that's not the way to treat or approach a pregnant woman with having a mental health issue. I do this all day, every day in my office, and I work in the community where I grew up and I live in. And so these are my neighbors, and I take really good care of them. If they come to me and they've got a mental health issue, if they're on an antidepressant or another psychotropic medication, you don't make them feel guilty. You don't embarrass them. You treat them with kindness, with sympathy, with dignity, and you work with them for coming up with the best plan for how to manage their mental health issue during the pregnancy. And I always tell them that the goal, we don't tell you, look, you're pregnant, so you just need to suffer and do poorly. That's not the way to treat a pregnant woman. So I wanted to just put that out there or be clear about that, because I think people sometimes mistake a discussion about the chemical effects of the antidepressants on the developing fetus with a discussion about how pregnant women on medication should be managed. And I just want to be clear that those are two separate things. With that being said, I think that your question's a good one about effects, about fetal effects. As you were saying, there's been a lot of recent controversy about that whole model of there being a serotonin deficiency, and Joanna Moncrief's paper that came out that got a lot of attention this past a few months ago. I think serotonin. It's important again to focus on the science of it. Serotonin is a crucial cell signaling molecule. It's a neurotransmitter, and it modulates developmental processes, like cell proliferation, cell migration. Basically, when it comes to the brain, like wiring the brain, circuit wiring for the brain, it acts as a chemical messenger. So that system is crucially important. And in a developing baby, right off the bat with the embryo, those serotonergic neurons, that serotonin system is important early in the development of the embryo, and then it goes on from there through development. Serotonin plays a crucial role in development throughout the fetus. In particular, the brain. That's what we tend to focus on with questions about neurobehavioral issues, but also in the gut, in the bones, etc. Serotonin it's a crucial cell signaling molecule, a crucial neurotransmitter. Which then gets back to what we were just discussing, which is that if you take a chemical and you alter the function or that serotonin system, how that normal serotonin system is supposed to work, it'll have consequences. You'd expect to have possible complications with that, and I think we do see that. The studies on antidepressant use in pregnancy are numerous and challenging for a variety of reasons. There is no randomized controlled trial for antidepressant use in pregnancy. It's not considered to be ethical to take a group of women and randomize half of them to the drug and the other half to other treatments. That being said, we still have a lot of accumulated data over the years to be able to kind of look at these things. Right now, my reading of the literature is that there's links to miscarriage, to birth defects, to preterm birth. Also a condition called preeclampsia, which is a well-known complication in pregnancy where the mom gets high blood pressure, typically protein in her urine at the end of pregnancy. Also postpartum hemorrhage. Women are at higher risk of postpartum hemorrhage who are on SSRI antidepressants. Gov.uk, actually, there's a warning that they put out recently about this, that the UK put out on that. And then from there, there's the newborn behavioral issues, newborn behavioral syndrome, which we can get into this more, but a constellation of problems or issues for the baby, including agitation, restlessness, irritability, poor feeding, trouble sleeping, low blood sugar, hypoglycemia, trouble with warmth regulation, hypothermia, respiratory distress, hyperreflexia, tremors, seizures. These things, some degree of them go into this newborn behavioral syndrome, which is more common with antidepressant exposure in pregnancy. This all kind of hangs together, I think, with a chemical exposure to a developing fetus and to the mom in as far as like postpartum hemorrhage goes.
And Adam, forgive me, I should know this from watching your talk, but I can't quite remember. So obviously SSRIs are made such that they can cross the blood-brain barrier, to get to where I suppose the sites of activation. Does that also mean that they can cross the placenta? Do we know that?
Absolutely. Yeah, it's a great question. I should have led off with that. I was sort of discussing that with that assumption, but that's an important point to make. They do cross the placenta for sure. Those studies have been done where we check the baby's cord blood, where we sample, and you can find levels of the antidepressant in the fetus. For sure, they're crossing over into the fetus during pregnancy throughout development.
Yeah, that's hugely important, isn't it? And, I also want to say that, when you, again, referring back to your talk, when you talk about the evidence supporting, the risk of harm to the fetus from SSRIs, you're quoting papers in the big medical journals, aren't you? So this isn't fringe science, is it? This is really, quite well established evidence that's sitting in some of the biggest medical journals about this.
Sure, absolutely. Yeah, no, that's exactly right. Um, in fact, just recently, the CDC group, this was a few years ago, put out their data on birth defects, which showed a link to birth defects with the antidepressants, in particular venlafaxine, but also the SSRIs as well. Effexor's an SNRI. This is published in a big journal, mainstream journal. This is Mainstream Medicine, and also on the CDC's website for that matter. If you look up birth defects with use of antidepressants, you will find that the CDC does highlight that study that did show that link.
And you were talking about some of the kind of behavioural issues that might affect babies that have been exposed before birth, and I guess there could be issues after birth as well, aren't there? So I understand that the children born of mothers who were on antidepressants can experience neonatal withdrawal syndrome, and I wondered if you had come across that, whether you had an experience with it, what might be the effect on the baby when this happens, and how can it be managed?
If you think about these drugs, we know that they can affect serotonin signaling. They're selective serotonin reuptake inhibitors. We believe that that's what they're doing. They're having an impact on the serotonin system. If we say scientifically that, okay, we know they affect the serotonin system, and we know the serotonin system is crucial for the developing fetal brain. So if you put those two parts of the equation together, then you can conclude that there's going to be impact on the developing fetal brain from a fetus being exposed to an SSRI antidepressant or other antidepressant throughout pregnancy, throughout the development of the brain. And we're actually, and we do see that in particular, we see that right off the bat with the newborn behavioral syndrome. People will also call it the newborn withdrawal syndrome, but it's believed to maybe not be just withdrawal. And the reason for that is we see some of these things right from the get-go. And so the other thing that kind of points to that is that there's a very interesting study that was done back, I think it was done in 2011. I believe the lead author was Mulder. And he did a very interesting study where he looked at women who he knew confirmed users of SSRIs and followed them by ultrasound, the fetuses, and compared them to depressed women not on medication and also to just normal controls. And that group was able to demonstrate changes in ultrasound parameters, particularly with behavior of the fetuses throughout pregnancy. And we saw, for example, in the third trimester, the fetuses exposed to the antidepressants, I believe, were getting less non-REM sleep, and they were more sort of active, more motion. So we can see some of these effects even in utero, which again, to me, makes sense. You're putting a chemical into the fetal brain that can affect the serotonin system. The serotonin system plays a crucial role. Serotonin plays a crucial role in development of that brain and cell signaling, et cetera. So if you're doing that, you'd expect that you might see effects. We do see some of those effects. And then after birth, we see these effects. Looking long-term or longer term, it gets harder to study. And those studies are mixed, but there certainly is a signal for things like autism, ADHD, language processing, motor function. Also, there's been a recent paper looking at gastrointestinal complaints, which again would make sense because of serotonin's important role in the gastrointestinal system, both of the developing fetus as well as adults. It plays an important role. So I think that it sort of hangs together scientifically that if you're using this chemical that affects serotonin, and if serotonin does play a critical role in fetal development, then there are likely to be complications and concerns with that.
Yeah, absolutely. Absolutely. Thank you, Adam. And yeah, you make such an important point about the delicate balance needed to help people understand what the risks might be and to help them make the best choice for them and their child and their family. So, I wondered if we could talk about this. You're a clinician now. So when you are counseling a woman or a couple who might be thinking of having children, what do you tell them? How do you balance that need to give them as an informed consent as possible? Bearing in mind they might not have had the information they needed when they started on SSRIs, balanced with how they make the best decisions for them and their family going forward.
Sure. So this is a really important point that and I'd like to make, that I think that this message and this counseling really needs to go out to women of childbearing age, as opposed to trying to address it once the woman's pregnant. And maybe the major reason for that is that these drugs, as we're realizing more and more, are very difficult to get off of for many patients. And so you don't want to be throwing in, typically, it's hard to throw in withdrawal into the mix with a patient who is newly pregnant and undergoing all of the challenges of the first trimester with things like nausea and vomiting, exhaustion, and the sort of changes in your life that occur when you get pregnant. And so it becomes a very difficult conversation to try to sort through at the time of pregnancy, at that first visit, in that first trimester. And really, this is a message or education that needs to go out to women of childbearing age and physicians who take care of women of childbearing age. And I think you could argue a message that should go out to everybody, which is, what are these risks, and potential benefits, alternatives, et cetera, and whether or not you want to be on them. So I think that when they're pregnant, we do, as I was saying earlier, which is that I tell them that, we don't want you suffering, and you treat them with compassion, and you don't make them feel guilty for being on something, and you try to individualize it. A lot of people look for just the one-size-fits-all answer. Should women be on them or should women be off them? What's the one-size-fits-all answer? And it really doesn't work that way. If a woman is on a medication that she's stable on, she's doing well on it, and she feels that if she comes off, she'll do poorly, she'll be suffering, she won't be functional, then that is something that has to be taken into consideration with the counseling as well as with her desire to stay on the medication. And I have a lot of patients who do that, who stay on the medication during their pregnancy. And when they make that decision, I support them, I take good care of them. That's the way I think to handle that or address that. Going back previously or before they get pregnant, really during the preconceptional time or the time that the drug is started, though, is where I think there really needs to be this effort to let patients know, patients in general, in particular, women of childbearing age know, look, these are the risks of the medication, including the difficulty with coming off of them, the difficulty with stopping, and that you may end up pregnant on this medication and with these issues of fetal exposure and potential pregnancy complications and fetal complications. I think that needs to be weighed more into the calculus than perhaps it is.
It probably is an informed consent issue as well, isn't it? That when people start these drugs, many, I know hardly anybody that was told when they were prescribed SSRIs or even antipsychotics for that matter, that they can be difficult to get off. So of course, if they might be planning on becoming pregnant, then they've no idea that there might be a bit of a hurdle there for them to do that. And I read recently that, the fact that antidepressant and antipsychotic use in pregnancy has doubled in the last decade. I think you actually shared a paper on that recently. So, should we be concerned about that? And should we be trying to ensure that informed consent for, maternal age women is somehow strengthened?
Sure, absolutely. Yeah, I look at this again through a lens of chemical exposure and just stepping back from it. If you're asking the question that we've got a doubling of chemical exposure now to pregnant moms and their developing babies, is that concerning? Absolutely. I think it's important to take mental health seriously. I think it's important, as I was saying, before, to provide good care. But I think that given the science on this, and again, this gets into the science of what kind of evidence of benefit we're seeing, which looks in many cases to be quite small, or absent, and certainly looking long term at how patients are doing, it looks like that the longer term outcomes are not the rosy picture that was originally painted of these medications when they came out.
Yeah, yeah, absolutely. And so then, we talked a little while ago about evidence of exposure harm being in the big medical journals. So, with this kind of knowledge within the medical community, I just wondered, what the response of the regulator, the Food and Drugs Administration, has been to these issues.
It's been, I would say, woefully inadequate. I think that we're not doing a good job with drug regulation in our society, in the United States and probably around the world. We're really dropping the ball on informing the public about medications, about their effects, and with the issue of drug regulation. We may get into McKenna. McKenna is a drug that we use in pregnancy, or we had used in pregnancy for about the last 20 years in the United States. It's a synthetic hormone, a synthetic chemical compound, a synthetic hormone that was being injected into women to prevent preterm birth. It was FDA approved in 2011. It was being used even before then, but its subsequent evidence has shown that it doesn't work. It doesn't appear to actually stop preterm birth, and there are risks associated with it. When you step back from that and you sort of look at that, you say, "Geez, we've been injecting pregnant women with a synthetic hormone that doesn't work for basically the last 20 years. Something has really failed there, and I think it's been a failure of drug regulation. And I think that's not just on the issue of McKenna. I think that's in other areas as well. I think we need better warnings for the public. If you look, for example, at the labeling on the SSRIs or Prozac, there is a medication guide at the end of the label. But I think most patients and probably most providers aren't looking at that and aren't addressing all of those issues. I would recommend anybody listening to this podcast to read through that medication guide, because the FDA there is highlighting many of the problems with these medications, many of these chemical effects, but it doesn't seem to translate to actually getting out into the public this information as well as it should, so that people are more aware of these things.
Yeah, yeah, absolutely. That's a really good point, Adam. Thank you. And I am one of those sad individuals that has actually read through the leaflet of the drugs that I had, and there's a big section under the lists of adverse events where it says incidents unknown, and there's a whole list under there. And of course, you could read that and think, oh well, because it's not known, it must be so rare that that it's not worth capturing. But actually, I believe that incidents unknown means it could be a major problem, but there's just not enough research to prove one way or the other.
I think that's a great point. Absolutely. The incidents unknown shouldn't be reassuring. It'd be quite concerning that's there. I wanted to just highlight in that medication guide, one of the things that they say is that before starting Prozac, tell your healthcare provider if you are pregnant or plan to become pregnant. It is not known if Prozac will harm your unborn baby. That's the unknown that you're getting at, that they're basically laying that out there. And that's what patients always ask in the office. That's what they want to know before they're taking a drug or being exposed to anything. Pregnant women will typically ask, can this hurt my baby? Can this affect my baby? And it's actually, pregnant women are smart about these things as far as trying to minimize exposures to things that could harm their baby. And so I think that we need to do a better job at getting that information out there, that there is evidence of harm. There is scientific evidence of harm, and that needs to be put into the calculation for moms and families when deciding about these things.
You kind of remind me, Adam, that, here in the UK, we did have a terrible experience in the late 1950s with the drug thalidomide. And interestingly, although our regulator didn't block it, it was blocked, I believe, by the FDA in the US. But, the fallout of that was just horrific. And, we must avoid any kind of situation like that with a drug that causes such terrible problems for babies and for mothers.
Yeah, no, it's very sad that, as you said, that the FDA was able to block that, and subsequently we've seen that they haven't done, I think, or aren't doing as good a job, and certainly not with McKenna. The McKenna story I talk about a lot because it's active right now, but it was initially approved based on one very flawed trial, very flawed trial from 2003. It was a lot of problems with that initial study, but it was given accelerated approval in 2011. Accelerated approval, the idea of that is to get drugs onto market that have a significant need, and preterm birth was a significant need. So they got it on the basis of that one study. But the idea was that the company would be required to do a confirmatory trial in short order or quickly to be able to actually demonstrate a benefit, but it didn't happen quickly. This went on for years, where we kept giving pregnant women this drug until finally in 2019, so 8 years after the initial approval, finally the second study results became available and showed that the drug actually didn't work. In the meantime, thousands and thousands of women had been exposed. The company had made billions of dollars off of the drug. But what's really disappointing is that even after 2019, it was March of 2019, in fact, that became known that the drug didn't work. Even from that point, the drug still hasn't been pulled off the market. The FDA has called for it. There have been a few meetings on this. People think that it's imminent, that this is going to occur. But we're almost 4 years now after the drug was shown not to work. The confirmatory trial failed. We're now 4 years after that, and it still hasn't been pulled off the market. There are still women that can be injected with this ineffective synthetic hormone that carries risks.
Yeah, absolutely. And I could be wrong about this, but wasn't there some issue about it being preferentially used for black women over white mothers? Was that true?
I'd see that as just sort of corporate or big pharma spin at its worst. The trial failed, the confirmatory trial failed, so they were trying to salvage it by saying that, well, the first trial was done with a lot of black women in that trial, and the second one was done with few black women, so we can look at this as a drug that helps black women, and we shouldn't take a drug off the market that helps black women. They were basically using a racial equity argument, which I thought was misleading and unethical, because actually the FDA had looked at both studies based on race and had not found that it made any difference. In fact, the initial trial, the trial from 2003, did not show a selective benefit in blacks. That was being done, I think, as I say, that sort of corporate spin at its worst, a way of trying to salvage the drug or keep it on the market by using a misleading racial equity argument that fortunately it looks like the FDA didn't buy, and we're hoping that the withdrawal of the drug is going to be imminent, although I've been feeling that way, I think, for the last 4 years, since 2019, but hopefully this is going to be coming in the pipeline soon. I did just want to make a comment going back to something you'd said about, in particular, to pregnancy. Pregnancy or developing a baby is a time where there's a lot of development, a lot of change, a lot of rapid change. So when you've got a rapidly changing or rapidly developing biologic system, it's particularly sensitive to these chemical exposures that I'm talking about. And so I think that that's, why in particular, obviously we're concerned with pregnancy for the developing baby, but in particular, we can see harms because we've got a rapidly developing biological system that we're then putting a chemical exposure into. And I think that leads to the possibility for more harm. It's interesting because another area where we see sort of a rapidly developing biological system is, for example, in sperm formation for males. And when the studies have been done looking at SSRI use and sperm and semen analysis, we see an effect from SSRI use on semen analysis. We see DNA fragmentation. We see lower concentrations, and so that's another example of a sort of rapidly developing process, sperm or semen formation, that's being subjected to a chemical exposure, and we're seeing results from that. Several studies have shown that.
Yeah, absolutely. It's so important to have these discussions, isn't it? Because it's really not, if these papers are in medical journals, then that's great. But for the average person in the street, they have little to no chance of actually getting at the information that they need to make some really pretty fundamentally important decisions for themselves and their families.
This is a huge problem, trying to get the information for patients. It's a big problem. And I think that part of that honestly speaks to the power of the pharmaceutical industry, the drug and device industry. Our system of regulation, as well as our system of informing the public, has become rigged, and it's being rigged by corporate cash. It's being rigged by big pharma cash, I think, is the way to think about that. I guess I'd encourage listeners to think of, like, in an ideal world, you would have drug companies trying to come up with drugs, and then they would come out with these, and then you would have an aggressive academic community, your universities, your experts, your specialists, who would really go over that data with a skeptical eye, and would really try to probe and see, does this stuff work? Is this going to be good for the public? So my vision of how this should be working would be, your academic centers, your academic medical centers, really holding pharma's feet to the fire and looking at these drugs and investigating and standing up for the public. And your FDA would also function the same way. They would stand firm and strong for the public. But what's happened is that the FDA is funded by the pharmaceutical industry, and many of the FDA folks leave the FDA to go work for pharma. It's a revolving door. And the same thing is true in academic medicine. Many of your leading universities are funded by pharma. The researchers are funded by pharma. So you end up with the pharmaceutical industry basically creating what I would call a corporate conventional wisdom around drugs, whether it's McKenna for preterm birth or antidepressants. The pharmaceutical industry creates that corporate conventional wisdom. Typically, they roll it out with it's a corporate rollout with a story, with spin. You've got a serotonin chemical imbalance. We give you this drug, corrects the imbalance, makes your life better, everyone's life better. They roll that out, and then they're assisted in that rollout. I mean, nobody would believe it if it were just the pharmaceutical company saying this. But when you've got your leading academic medical centers saying this, when you've got your experts saying this, and when you've got the FDA approving these things, it creates this conventional wisdom and this information for the public that's going to lead to increased sales. And that's the whole point of it. The reason why the pharmaceutical industry is showering cash on academic medicine and showering cash on the FDA, and the reason it works this way, is that ultimately it leads to increased corporate profit, increased drug sales, which is what they're aiming for. That doesn't, though, work for the best for the public. So we really need to get back to where we've got these, what I would call the medical establishment, where the medical establishment, and that would be the physicians, the academic medical centers, the researchers, the FDA, the CDC, where these folks are all working on behalf of the public, rather than on behalf of the corporations, on behalf of big pharma and the device makers.
Do you think there's a chance of that change happening? Because as you said, there's so much money generated in sales that the pharmaceutical industry can buy power and influence. I think it's one of the largest lobby groups in Washington, isn't it?
Yeah, I think that how to solve this is challenging. I think getting independent voices out there like this is really important, and I think having a wary public, a skeptical public, actually does help with this. And at least from what I'm seeing, just in general and also in my office, I think the public has become informed and is skeptical and wary. I think that they feel like, oh, all these people are being paid by the pharmaceutical industry, and it creates a lot of skepticism. And I think you're seeing that's becoming more prevalent in society, where people just aren't buying these recommendations. You can have a recommendation that you need to take drug X, Y, or Z or whatnot. You can have that recommendation come from the FDA, the CDC, the leading medical societies, and the public will often say, no, we're not going to do that. And I think that's what we're starting to see, where there's this disconnect between these official recommendations and what the public is saying on these things, which is that they're going to refuse it. They're not going to do it. You can only play the game where you buy. From a pharmaceutical industry standpoint, you can only play that game where you're buying off, or where you're paying the regulators, you're paying the researchers, you're paying, and you keep getting the result you want. You can only play that for so long before people realize it's a rigged system. And I think that there are a lot of people that are becoming more and more aware of that, and are looking for unbiased voices in this, and trying to drill down and figure out what the actual accurate information is.
Yeah, absolutely. Absolutely. Thank you, Adam. Is there anything else that we hadn't touched on that you thought it was important to?
I think probably the biggest thing is what I interjected in there previously, which is that the discussion of what an antidepressant is doing to a developing fetus is an important one, and it's a scientific one, and it has to do with chemical exposures and embryonic and fetal development. But that is a different question than whether a given individual mom in my office or in any office should or should not stay on her medication during pregnancy. Pregnant women with mental health issues deserve compassionate treatment, good care, and shouldn't be made to feel guilty or ignored. And the counseling needs to be thorough and comprehensive and supportive. And so my concerns about fetal exposure are not meant to in any way disregard the importance of mental health, or ignore pregnant women with mental health issues, or not be sympathetic or compassionate to them. That being said, I do think it's very important for accurate counseling for women to be able to get them the information about what the effects of these drugs are on developing babies. So I think that's important. The second thing I would say that's important in summing up here is the point that we've made several times, which is that chemicals have consequences. Don't forget, when you're taking a medication as a patient, when you think about medications, remember they're drugs, they're medications. These are synthetic chemical compounds. They're made in chemical manufacturing facilities, and they're going into your body, and they're typically going to have widespread effects. And so it's important to sort of keep that in mind. We often aren't shown that. I always like to joke when I give lectures on this that in the food industry, the orange juice makers, they want to show in their ads the orange trees and where it comes right off the tree, right? You don't see that in the drug commercials. You get the people in a bathtub and the ocean and whatnot, but you're not seeing the chemical manufacturing facility where everybody's dressed in the white chemical suits and the goggles and shields, making the chemicals that are then going to come out and ultimately be going into your body, into your brain and other organs. So it's very important to keep that in mind as a patient, as a citizen, as a consumer. These are chemical compounds, and they have chemical effects. And then I guess the last thing I'd want to emphasize is that this important talk really needs to happen with women of childbearing age prior to pregnancy. We really want to address these things not when they come in at 8 weeks or 12 weeks, or whenever they're coming in during development. You really want to be addressing these things earlier, and addressing it also in general with the public, about trying to inform the public about the risks, benefits, and alternatives to antidepressants specifically, but also medications in general.
Adam, thank you so much. You've done a beautiful job of explaining the science for us, and telling us how important it is to have a human approach to these issues when you've got someone in front of you who needs advice and who might be in a difficult position and might have to take some difficult decisions. So I can see from talking to you how much that means to you as when you're counseling women and couples. So and I also can't imagine it's very easy to be a critical voice and to speak out on these issues, given the resistance that's encountered. So thank you for all you do, Adam, and thank you for joining me today to talk about it for the podcast.
Yeah, thank you as well. I appreciate the opportunity and being able to sort of get the word out on it. I appreciate your work, and thanks for giving me the opportunity.
Well, I just want to thank Adam so much for taking the time to chat. As I mentioned at the start, his MIA continuing education course on antidepressants in pregnancy is both informative and comprehensive. To find it, visit the education section on madinamerica.com and enroll as a student to access this free course. So, as always, thank you for listening today, and until next time, take care. Thank you for listening to the Mad in America podcast. Visit madinamerica.com for more news, views, and updates.